the last 2 years have really been tough on everybody. But one of the things COVID really shone a spotlight on was the fact, and of something that many of us knew, but COVID really brought it to everybody's attention. And that is that health outcomes in this country and across the world are inequitable. Different communities suffer more than others. And as a program that is national, the CTSA program, we have a certain responsibility to think about how we can advance health equity. And so it's my great pleasure that 3 CTSA leaders from across the country, Ebony Boulware from Duke, Mario Castro from the University of Kansas, and Becky Jackson from Ohio State, have agreed to join me this morning in a keynote panel that will address this. Each person will give a brief talk, and then we will open it up for this discussion. So I'd like to invite Mario to come across and join me physically, and Ebony and Becky will join us virtually.
Certainly a few things have changed since I've been here a little bit over 2 years ago. The Queenie Tower coming down was definitely a big change. I remember going up that tower many times. But I'm delighted to come back and share with you some of our work and efforts in terms of diversity, equity, and inclusion. And I would say, thanks to Dr. Frazier, a few years ago when we started the Office for Faculty Development, really this was the starting of that effort in terms of diversity and inclusion, and a lot of the lessons learned from here I've taken and certainly expanded within our program. We call our institute our CTSA Institute funded Frontiers, just so everybody has ICTS or CTSI, and so we try to distinguish ourselves. And we're currently going to start our third cycle of funding. And we're really excited about this next cycle, and that we're really going to be expanding our efforts inclusive of diversity and inclusion across all of our functions within our CTSA. So when we think about Frontiers, our aim is really to build our workforce is one of our aims. And how do we do that in a way that allows us to be creative, responsive, and impactful, as noted here? And so I'll talk about some of the things that we are doing to build that pipeline to really successful clinician investigator that is coming sometimes from disadvantaged backgrounds. But we also recognize that there are importance in terms of looking at the D&I lens in other areas, not just in our investigators, but also in our support staff, our coordinators, our administrators, and especially those that are out in the community. And so when we think about that diversity and inclusion, we need to think about it across that entire spectrum. And we think about it not just as an underserved population, both racially, ethnically, but also in socioeconomics, but also from my perspective, and I was very happy to see that WashU's CTSA, ICTS has expanded into rural areas, and certainly we in the University of Kansas serve the entire state of Kansas in Western Missouri. So we have a very strong need to serve the rural population. And of the 60-some CTSAs across the country, there are only about a half a dozen of us that are really addressing that rural population. So there's a huge unmet need there. One of the things that we talk about is workforce heterogeneity, with the lens that when we address D&I efforts within workforce, that we're able to really improve our workforce from the standpoint that they're more effective in the job that they're doing, and that they're received in a different fashion. And This paper that Bridget Jones, one of our leaders within our CTSA Frontiers, was an lead author on, really talked about this from the standpoint of looking at trainees, and that they often come from various geographic locations that put them at a disadvantage. There's really an inadequate diversity amongst the candidate pools, and sometimes that's used to give as a reason not to focus on D&I. There's really poor coordination of resources to recruit these candidates. There's recruitment bias, and as we all know, sometimes that bias is silent or really not recognized, but we need to take active efforts in terms of that recruitment bias. And then limited financial resources. And so when you put this into play and you put attention to it, it's actually been shown that physicians connect better to their underrepresented minority patients. And then even white trainees that go to a program that address these issues feel more comfortable, feel more empowered to work with minority populations. And so it is an effort that is very important to address not just from our underrepresented minority trainees, but also across the board. When we developed our training center, certainly mirrors a lot of the training center here at Washington University. Our Frontiers Training Center is really guided by an advisory committee that is diverse and has community representation and engagement involved in that regard. And so they're involved in looking at all the strategies that we take in terms of our training and how do we strategize even in reaching out to our trainee pool. Where do we go? Where do we visit to talk about recruitment for our trainee pool? We talk about things that the trainees are working on, and we utilize our advisory committee to provide us feedback in that regard. And then one thing that we've really worked very hard in this next cycle of our Frontiers is that we have diversified our leadership. So each one of our core representations within our CTSA has co-leadership, often being racially diverse, but also gender diverse in that leadership. And then lastly, sometimes senior and junior diversity we recognize also is very important in terms of faculty leads, so that it allows us to create that natural building of infrastructure for the future in terms of leadership. So we believe that this is critical. And then the last point here is mentorship. Our advisory committee is very keen towards making sure that our mentorship is appropriate and that it's diverse itself and leads to comfort amongst our trainees to represent that. Now, in our Frontiers Training Center, we have a number of initiatives to address diversity. We have a research professional pathways initiative that is modeled after the Duke model and also based on a workshop that was developed in terms of training the future workforce for clinical research. And in this professional pathway, we recognize that there is need from the administrator working with research to the investigator to the research coordinator or research assistant, and then to those members in the community that are involved potentially in that research project to be trained adequately. And at that time, we also address diversity, equity, inclusion in that training for our workforce. We have an entrepreneurship roundtable. This is primarily directed towards trainees. We work with this roundtable with business leaders in the Kansas City region community, but we also have partnered with Mizzou as well, which has a wonderful entrepreneurship program that Embark that we have been involved with as well. And and support, because it's really a mechanism to really advance in an entrepreneurship role. We have health equity initiatives that we've incorporated throughout our program. And this is specifically to make sure our trainees are addressed on unconscious bias and also racism, and really thinking about anti-racism efforts as part of the training and incorporating that throughout those. So those are new health equity initiatives that we have implemented within the program. And then lastly, in the pilot program, which we all apply across the CTSAs, is a great source of funding. But what we've done is we've given a little bit of a bonus to those pilots that say, I'm going to address an underrepresented group in a certain way. And it could be either by engagement of that population, or it could be by addressing methods that would be important to that population. So they give a little bit of a bonus to those pilots. Now, we have even a harder job than WashU in terms of our partnership across the CTSA, in that we have an additional 5 partners represented within our ICTS at Frontiers. And so, and we have partners both across the state line, and we also have geographically dispersed partners all the way down in Wichita, Kansas, Lawrence, Kansas, but throughout Kansas City. And of course, we have representation from our pediatric group at Children's Mercy. This has been our biggest challenge often, because they're at various levels of engagement. They're at various levels of their own research programs. And how do we build that infrastructure within that to ensure that we have a diverse workforce across those populations? I just want to give you a couple of examples how we do this. In partnership with Children's Mercy Hospital, we have the STAR program. The STAR program, similar to Aspire here, allows underrepresented and disadvantaged individuals at the high school level, college level, to go through training in clinical and translational research over the summer. And that has been widely successful program and highly represented by underrepresented minorities. But again, recognizing that you can be disadvantaged in different ways, not just by race and by ethnicity. The second program is in partnership with Kansas City University. Kansas City University is one of the largest training programs for DOs. And in that program, they not only train DOs, but they also train at a master's level and offer a master's of science in that program. They have over 130 MSCI type individuals. 20% of them come from underrepresented minority groups. We believe that is part of the pipeline that we should encourage, and so we have incorporated them within our ICTS. We do individualized training with them, often what we call the pre-K workshop, recognizing that they may not be ready to write that K, and so they need a little bit of counseling to get them there. But again, it's this diverse effort, trying to get to each one of our partners at the level that they need to address diversity. Now, I think Ebony will be addressing a lot of these areas. There was a recent D&I workshop that occurred across the CTSAs, addressing institutional, programmatic, community-centered, and social-cultural environmental efforts. And this is available, and I encourage you all to review that, or that are involved with your CTSA here. I'm happy to say when I looked through it, I said like, well, yeah, we meet those check boxes across many of these areas, and certainly stronger in some areas versus others. But this is really a good document to allow you to kind of think about how are you doing within D&I, and I'll let Ebony address that in more detail. I want to delve just a little bit into our training programs, our TL1 program. We have both a pre-doctoral and a postdoctoral component to our TL1 program. And as noted here, we have recognized that this is critical that we increase the diversity within our training programs, both at the TL1 and the K program. And so we've been successful in this past cycle to increase our underrepresented minority involvement within our T program to 50%, which has been outstanding for us to really move the needle in terms of trainees that are involved with the program. And at our postdoctoral level, it's around 20%. But this allows us, again, to focus, not necessarily trying to hit any particular quota, but it is allowing us to really focus our efforts in who we want represented within our trainees at both the pre and postdoctoral level. And again, making sure that gender is addressed as well. Then at our K program, we have expanded our leadership. And so within our K and our T program, co-leadership now, we have women of color that are represented now as leaders within the program. And I'm happy to say some of them are actually graduates of our K program, which is wonderful because they understand all the things that our trainees are going through. And so they have set us a very high bar within this next 5 years that we are going to hit 35% enrollment of underrepresented trainees in our clinical and translational science program. And we're doing that by, again, working on that pipeline that I mentioned, providing that early support, these pre-K or pre-T workshops, targeted recruitment at our national conferences, but also those conferences that Latinos and Native Americans attend that can also be targeted. And then really making sure that each of the departments that are recruiting individuals have an effort dedicated towards addressing D&I efforts. And we have School of Medicine support for that. Our Vice Chancellor, we have a Vice Chancellor specifically in charge of D&I efforts. When we think about our trainees, again, it's trying to address these multiple domains for our KL2 trainees and trying to make sure that they have adequate mentorship, adequate leadership, and really that network that is so critical for their success. We also make sure that the mentors are appropriately trained and go through not only mentorship training, but also specific in how to address D&I efforts with their trainees themselves. So I just want to end with one last program that we started last year. If you've not seen this movie, Black Men in White Coats, or read the book, I encourage you to do that. The website is listed here. We're taking this now to the next level. So we're actually incorporating individuals at a very young age that are interested in STEM within our region to participate this fall within a Black Men in White Coats event that we're going to have on our campus to really, again, break the barrier that often they see coming from various communities of how could they get into medicine. You know, they're coming from very different exposures. And so we're excited about this upcoming event from Black Men in White Coats. Thank you.
Thanks, Mario. We will take questions for the three presenters on the entire topic at the end of the presentations.
So it's just a pleasure to be here for this symposium. Thank you so much for inviting me, and I really appreciated hearing the comments from Mario about what's happening at Kansas. And I'm actually not going to be speaking so much directly about diversity, equity, and inclusion, but I will. I'm happy to answer any questions about that. I think it's related to what I'll be talking about, which is sort of generating an equity mindset throughout translational research. By thinking about our science, no matter where it's placed in the translational wheel, in terms of equity. So as Dr. Powderly said, you know, the goal of translation is to make tangible improvements in health for individuals, communities, and whole populations. And in order to think in that way, how we take a discovery from the lab all the way into practical community implementation, we really need to kind of think about our science in with a holistic mindset, placing our discovery within a common framework. And to do that, I like to think about that then. One of the ways that I think are very effective to think about that is to think about health and health equity as goals for our translational science. And I start off with some key definitions. Health being the state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And it being influenced by multiple and layered molecular, physiological, behavioral, social, and environmental contexts. And I'll illustrate that a little bit more in a moment. And health is really, rather than our traditional focus, I believe, in medicine on disease mechanisms and disease, it's really more of a flipping of that, not necessarily the inverse, but a positive concept, which emphasizes the importance of social and personal resources as well as physical capacities as we sort of holistically achieve well-being. And then health equity being defined as the absence of unavoidable, unfair, or remediable differences among groups of people, whether those groups are defined socially, economically, demographically, geographically, or by other means of stratification. So this is a framework that is a socio-ecological, biosocioecological model that I've adapted from other groups that has been around for at least a decade, that really talks about the layered influences of our social and environment on other contexts that influence health. And I call this the cells to community model. And I believe that, for the most part, the vast majority of translational research, regardless of what the targets are, could be placed within this model. Starting at the bottom, thinking about genetic and biological pathways that influence health. So here we're talking about molecular mechanisms, genetic mechanisms, epigenetic mechanisms, and those things really being embedded within physiological responses, hypertension, diabetes, other illnesses. Within that, these pathways being embedded within individuals who have their behaviors, their attitudes, so tobacco, alcohol use, et cetera, that also influence those biological and genetic and molecular mechanisms. That also then being embedded within a social context in which people's neighborhoods, where they live, the building quality, the orderliness and cleanliness and sort of health promoting aspects of their environment influence their individual behaviors and risks, and in turn influence those other more molecular pathways and physiological pathways. And then even above and beyond that, thinking about the society that we live in and how our economic systems, our legal systems, our norms, and prejudices may also influence all of these factors. So all of these factors contributing simultaneously to improving health as well as health equity. And the question I think is really important for us to begin to address within clinical and translational science from a number of angles is, how do we address equity at every angle, at every level of the model? I think when we say health equity, it might be a common response for individuals who are doing their research at the molecular levels to feel left out of that, because equity really is a concept that is socially driven in many ways. However, as we consider this layered contextual framework, we then begin to realize that if we're going to improve health and health equity, we really do need to think about the interactions of the multiple layers of these models. And so therefore, every scientific question should in some way be placed within this. So I think we can think about this from multiple different angles, including how we formulate our hypotheses for our science. So when we're thinking about, a genetic mechanisms, are there any epigenetic influences on the mechanisms that we're looking at, et cetera? So really beginning to layer and thinking about all of those influences, even as we begin to develop our hypotheses. And I'll talk a little bit about our hypotheses as well, but just want to say up front that we're moving to a spot, thankfully, in science, I hope, that we're beginning to recognize that certain types of contexts, such as race or ethnicity, are not biological contexts in themselves. These socio-political contexts, through their influences on environment and other contextual factors that influence people's the availability of resources, their capabilities of addressing certain biological responses, influence health, but that race and ethnicity in and of themselves are not biological concepts. They are social concepts and should be treated that way in our hypotheses. And similarly, as we think about our analyses and our data, how do we begin to think about how multiple different contexts might influence the outcomes that we're seeing? Our participants, how diverse are our study participants? Are we engaging individuals from a variety of different biological backgrounds, as well as social backgrounds, which are very important? And then where are we conducting our research? So when we do make mechanistic discoveries, particularly say we have drug discovery, what are the settings where that research is going to be implemented? Where are we conducting the research so that we're ensuring that we're doing it in settings that reflect real world circumstance? The targets that we choose for intervention, again, thinking about where across multiple of these different layers do we need to target if we're going to improve health equity or health. If we want to improve hypertension control, we may really be thinking that our target is going to be somewhere within the healthcare setting or within other settings that influence people's ability or capabilities to be prescribed or to take medications. So the target depends on what we're trying to achieve. And then I think we talked in the prior presentation a little bit about teams that we form. It's important for us to think about who's going to be involved in the research that we're doing, what perspectives are important to inform the questions that we develop. For example, if a study is going to be conducted, or if the goal of study is to improve uptake of hypertension treatment in the community, who should be on our team? Should we have community members on our team or other community stakeholders who can inform how we would actually get that treatment into that setting? And then, and similarly, our implementation partners. If something is going to be scaled into the health system, then perhaps we need to have health system expertise on our teams. So, and maybe I kind of went through these already. I talked about how we think about the contextual influences on our biological targets for the hypotheses. And I did talk about race or ethnicity. I may skip through these kind of quickly because I sort of said what I wanted to say. One of the things I'd say about the types of data that are needed, increasingly we're seeing that when we're looking at health and health equity, that we may need multiple types of data to inform a question. For example, we might be interested in understanding where individuals live and what their neighborhoods actually are like. So that for that kind of information, we may need data that includes census data or local data on things like crime or pollution or the built environment, things that can affect health that we typically don't look at, but that we have data that can now be merged with health data to begin to answer questions about social contexts that influence health. I talked a little bit about the participants reflecting the diversity of the user constituents. And I think we need to really be thinking going beyond race and gender to include other identities, including socioeconomic status and geography, and making sure that we have full representation across our population. I talked a little bit about the settings. And I think when we're talking about, one of the biggest challenges we often have, and we saw this with COVID-19 with the vaccine implementation, is even though we had very rapid translation in terms of making the vaccines available, we hit a major translational roadblock in getting the vaccine to the communities that needed it, particularly those communities that are marginalized and actually had the greatest rates of morbidity and mortality from COVID. So it implies that we're not necessarily working with our communities to ensure that these interventions will be trusted and taken up at the end of the day. So we can feel okay about developing the vaccine, we can feel great about that, but if the vaccine doesn't get to the recipients, we didn't achieve the goal of translation. I talked a little bit about the level of the target. If this intervention is to improve blood pressure control, we may address multiple targets. We may address things that happen at the vascular level, but we may also address behavioral targets. We may then also address things like food availability or other sorts of social factors that get in the way of people actually being able to take their medication, and including purchase it. If people are making decisions between purchasing food or gas versus purchasing their blood pressure medicines, then the target of our intervention may really be a policy intervention. I talked a little bit about the diversity of the team. I think as these questions around health and health equity become more complicated and we begin to think about these layered contexts, we need to think about getting multiple disciplines involved in our science. So we may have laboratory scientists working indeed with social scientists to begin to think about integrative approaches towards improving health equity. And then also involving our non-science partners, including community partners and other stakeholders. I did say this about the implementation and where an intervention will ultimately be implemented, and how do we engage communities and other implementers from the start of the study in order to make sure that when we finally get to the goal, that we're going to have something that can truly translate into that next phase. And then, you know, developing our intervention for a sustained impact is developing and doing things in a way that can actually be utilized by the end user, that we have a pathway for people to take it on. And that includes making sure that there are policies in place for people to utilize these interventions so that they actually can be used long-term. So I think this is the conclusion of my slides, but I believe that most translational research can be placed within a health and health equity model, but we have to get ourselves into an equity mindset, and it has us bringing our lens away from our own specific research question, which I do believe over history, we've been incentivized to look at very isolated mechanisms without putting them in the context of other mechanisms that influence the ultimate outcome. And so by placing our science within this context, I believe that we can begin to think about how to improve health and health equity broadly. It does require careful consideration as studies are designed and conceived, so that we begin to think of our question, our one mechanism within the context of multiple mechanisms that contribute to health and health equity. And we need to it may also require that we challenge traditional paradigms to ensure studies fully address equity barriers. So a common thing that we still see in science is when we look at health disparities, often looking at, if we see a health disparity, for example, by race, saying, well, what is different biologically among racially minoritized groups? And that really is faulty reasoning. I'd love for us to move away from that model. When we clearly say race and these other constructs are social constructs, we really need to understand what that means and not continue to reinforce faulty reasoning around race being a driver of health, but really that racialized policies and contexts are what influence health through contextual mechanisms. So I'll stop there and we can move to the next presentation. Thank you.
Good morning, everyone. And I'd like to thank the organizers of this symposium for inviting me to participate in this discussion on engaging community and academia to work together to promote health equity. Over the next 10 minutes or so, I just want to discuss another form of equity, that of data equity, and how our CTSA hub has incorporated these principles in our approaches towards clinical and translational research. I do apologize for not being on the camera right now, but germane to this talk, in fact, I am experiencing my own digital decide. May I have the next slide, please? At its most fundamental core, data equity can be defined as a consideration through an equity lens of the way in which data are collected, analyzed, interpreted, and shared. It serves as a framework to reduce bias in data interpretation by providing insights into how bias impacts every stage of the research and data lifecycle. This is really an intersection between community engagement, ethics, biostatistics, and informatics, and relies upon such fundamental principles as the inclusion of data on structural factors and historical and community context to reduce unintended biases, as well as ensuring that data democratization is there, such that everyone will benefit from the outcomes of the research that we do. Next slide. In 2021, Jagadish and the colleagues proposed a data equity framework based on 4 organizing facets that I think will be helpful to all of us in thinking about a data equity focus for clinical and translational research. First, representation equity embodies the concept that to reduce bias, we must bring all voices to the table to provide both context and insight. Feature equity focuses on ensuring that attributes such as race, ethnicity, gender, age, geography, and both individual and community-based social determinants of health are incorporated into our data collection, analyses, and interpretations. It also captures variables to provide insight as to who is not represented within the data that we are examining. Third is access equity, which ensures that there's equitable access to data sets and tools for all individuals. This includes an intentional focus on data literacy, so all stakeholders can interact with data in a meaningful way, and that no single solution fits all. And then finally, outcomes equity. This is centered on accountability and asks important questions regarding who is engaging with the data, whose voices are not being heard, and whether the data and its interpretation have resulted in fair and equitable benefits rather than unintentional harm. Next slide. The digital divide also impacts data equity, primarily impacting individuals who come from either low socioeconomic backgrounds or from rural communities. There are 3 different pillars of the digital divide: a lack of access to technology, such as smartphones, laptops, and tablets, a lack of broadband coverage and internet access, and low digital literacy, where people lack the skills to use online resources and tools. Although there have been significant gains in reducing this digital divide for rural populations over the last 10 years, primarily catalyzed by federal initiatives to address this disparity, our rural communities and our inner city communities still lag by more than 10 to 20% relative to those advantages seen by suburban and urban communities. Next slide. The final foundation for data equity is data literacy. Data literacy encompasses the ability to read, work with, analyze, and communicate with data. It enables all stakeholders and end users, from investigators to clinicians, to study subjects and patients, to ask the right questions, derive insights, inform decisions, and communicate meaning from the data with which they interact. By enhancing data literacy, we democratize data, and in turn, we can increase value for research, reduce bias, and facilitate translation of new approaches to improve human health. Next slide. Within our CTSA hub, we have begun to systematically address data equity as a fundamental factor impacting our ability of conducting clinical and translational research to improve health equity, based upon a foundation of responsible data sciences that's transparent, accountable, supports fairness, and encompasses diversity. We've leveraged our approach of convening, connecting, catalyzing, and enabling to affect change. Next slide. To illustrate how we put these principles into practice within our hub, over these last few minutes of my presentation, I want to highlight one ongoing case study as an example of how an intentional approach to improving data equity can be embedded in research that we support. The Healing Community Study is a multi-site parallel arm cluster randomized wait-listed controlled trial evaluating the impact of a multi-pronged community engaged data-driven intervention implemented within 67 communities across 4 states that have been highly impacted by the opioid crisis. The overarching goal of this study is truly audacious: to reduce opioid-related overdose fatalities by more than 40% over the next 3 years. Next slide, please. However, if one did not design and implement this study through a data equity lens, it is certainly possible that the Healing Community Study would have widened health disparities while still meeting its goal of reducing overdose deaths. As seen on this slide, the pattern of overdose deaths has been changing over the past several years, and the crisis now is not only a major public health crisis, but in fact one of a health disparity crisis. If our study was not informed by data that included demographic, geographic, and other contextual variables, interpretation of the results of the Healing Community Study would be misinformed, and we would not be able to address whether all people with living experience and the communities within which they reside would experience the potential benefits from the Healing Community's intervention. Next slide. The intervention for the Healing Community Study is a data-driven, community-centric change process where coalitions and research teams work to co-create data-informed decisions to select and implement evidence-based practices to reduce overdose deaths, increase uptake of naloxone utilization, medications of opioid use disorder, and decreases in unsafe prescribing practices. Data quality, transparency, and equity is central to the intervention and thus to the CTH success. Next slide. The process of ensuring data equity requires the development of authentic partnerships between 3 different stakeholder groups because none of us could do this alone. The community coalitions who provide community contextual variables and insight to improve quality and decrease systematic bias in the data we both collect and share. Our state partners who facilitate access to individual and community level data through our statewide data warehouse, the Innovate Ohio platform, as well as supporting policy changes that improve the incorporation of demographics and other psychosocial variables within our administrative data, and reducing the digital divide that decreases access. And finally, our academic study team who provides access to data and improves data literacy of both community members and our state partners by employing the DASH model. Next slide. Our efforts to keep data equity at the forefront of this study can really be mapped back to the facets of data equity as noted on this slide. First, we brought all stakeholders from coalition members across 4 different sectors to people with living experience and CAB and state partners to the table from the initial design of the study and across the full research life cycle, which is of course still ongoing. Second, through applying co-design principles with key end users who use the data to support data-driven, agile responses for resource allocation to reduce the opioid crisis, we provided opportunities to look at new data sources that might better meet the unique needs of different stakeholders and decision makers. We intentionally focused on inclusion of demographic, geospatial, and both individual and community-based social determinants of health. When data were not directly available, we adopted linkage and imputation techniques to provide more accurate estimates of contextual and structural factors, as well as using techniques such as capture-recapture for better prevalence estimates. Next, to enhance access, we created data dashboards that have both open access to community-specific, near real-time, as well as historic data with authenticated access to meet the varying level of needs while providing data security and protecting privacy of those who have so generously donated their data. In the development of data action plans with the community and in refining our data systems, we've enhanced data literacy with all our community members, which has led to a more than 2-fold increase in data engagement and now with meaningful use. Next slide. So what have we learned through our efforts? How can we translate these opportunities in the future? And what might be things for you to be able to start to think about that increase your data equity? We've been moving forward towards explicitly and intentionally addressing the following 7 challenges, which we actually see as potential opportunities for strengths in data equity for each of the studies that we've reported. First, do we meaningfully engage the community and/or patients as authentic partners in the data lifecycle? Do we accept them as valid experts that provide insights that will reduce bias and improve impact? Second, how do we further encourage open sharing of the methods for data collection, our analyses, tools, and our data sets to advance the public good? Third, are the data from each study actually truly accessible to all? Where technology inequities exist, can we define alternative pathways to support data sharing and engagement? Fourth, from the inception of the study idea through the dissemination of the results, has the value of the study for all people been clearly articulated? Who benefits? Where are there potential harms? And at what cost is this study being done? Fifth, are principles of responsible data science part of the fabric of all research that we perform? How do we capture this and actually share this information in the work that we do? And finally, authorship. Whose voice is shaping the narrative as we implement our results into practice? Can we put in place strategies to include more perspectives that will further define impact? Last slide. I hope these ideas are provocative to you, and I thank you for your attention. I look forward to our open discussion now and potential future collaborative opportunities as we all work together to improve data and health equity. Thank you.
We'll now open this for questions. For those of you in the audience, please raise your hand and we'll bring a microphone to you, because the folks are watching on Zoom can't actually hear your question without a microphone. And those of you on Zoom, please put your questions into the chat. There's a question here. Let me start. Thank you, all 3 of you, for really very informative and somewhat provocative talks that I think are incredibly important. But Dr. Jackson, let me follow up on the point that you made towards the end of your talk. Investigators traditionally are very much regard themselves as being in charge of the research. But as we engage more people into essentially a team building and that involves people outside the traditional academic environment and communities, how do we as CTSAs train the next generation to be comfortable sharing that control?
So I think that the key aspect of this is truly authentic and long-standing partnerships. And so this is really the same type of team-based training that CTSAs have had at their very core, but we've widened the tent and really brought everybody under that tent and working together. I think this does mean that one needs to put aside their own truth and be open and willing to share and consider new ideas, new perspectives, which really moves us from that, multidisciplinary research perspectives to interdisciplinary, but truly transdisciplinary efforts. I think that the rewards are incredible. It's not always easy. And sometimes you hear things that in fact you don't anticipate or in fact are hurtful. And that you have to think about, how do we remove that stigma? How do we engage in that openness? How do we hear each other, respect different ideas? One of the ways that we do it with our trainees, with our pilot program fundees and others, is to actually do team building activities with them and to engage them in how to do that and include community stakeholders and a wide range of individuals to work together and to actually practice at ways to be more collaborative and to have more open listening and sharing.
Okay,
me just build on that. Another example of really listening to the community and engaging them in the leadership came up recently with our COVID response. I know you all have RADx up here as well. And so we wanted to get the vaccines out to the communities of target. So one of our leaders, an African-American gentleman in our community, Broderick Crawford, stepped up and is a co-PI with us on the RADx Up effort and really helped us shape how we went out to the communities. You know, no longer asking them to come to our community health settings, but going out to their settings. We went out in Kansas. There's an old Kmart. Kmart doesn't exist anymore, but it's been converted to a health setting department. And we gave thousands of vaccines out into that setting. And that was something that Broderick really brought to the table.
I might also just build on that just a little bit too, which is just to say that as investigators, we need to start thinking about how to speak common language. You know, we use a lot of jargon and we haven't learned how to translate what we're talking about to a person who's not in our field. And I think that's critically important that we begin to train ourselves, no matter what level we are, on how to speak in normal human language when we're describing what we're trying to do, so people can really understand that and that can resonate.
And I guess I'd follow up in that, Ebony, and that's really part of the fundamental concept of data literacy, right? That people do not need to be a biostatistician in implementation, that what you need to do is have data speak to people at whatever level that they need to engage with the data. And so that there are multiple different ways. But if we're really talking about data democratization and health equity, then we need to be able to actually enable everybody to interact with that and to be able to ask the questions and be able to draw conclusions from all of the data that we have available to us.
It's interesting. I was talking yesterday on something related to this topic with another investigator whose site had brought more community representative into the review of pilot grants and similar type of grants, and essentially it created I won't say a bar, but it became a bar that if the grant wasn't written in lay language, that it wouldn't be funded because the investigator hadn't overcome the issue of communication of the value of the grant and the impact of the grant. And so that was an interesting strategy that was taken at an institutional level, at a CTSA level, to encourage people to do exactly what Ebony is talking about. We have a question here from the audience.
Thanks. I think one challenge in doing community engaged research that involves forming real partnerships with community groups is that it just takes a lot longer. And so I'm just wondering, for the people at other institutions, do you have plans that address that in terms of, because the traditional sort of faculty thing is trying to get tenure, and if that's going to take a lot longer. So do you have strategies for that, for allowing that extra time that it takes to build those sorts of relationships? Thank you.
I'm sure all of you have a thought on that. I'll start with Mario and
Sure.
Well,
it's a great point. I do think sometimes we have to reconsider the timeline for promotion and other things that we worry at the academic siding when we talk about community engaged research. We try to incorporate that in our decision making in terms of promotion and realize that sometimes their publication may take 2, 3, 4 years to get there, and maybe they need a little bit of an extension of their time in terms of the promotion. I do think also that when we're talking about publications and things that we care about, we should also include our community members. And so we set that out front in the project and say, your involvement in this project is going to lead towards a publication. We want you to be involved in that and give your perspective. So it's a lot of give and take that has to be on both sides.
Dr. Boulware?
Sure. Yeah. I mean, I think this is a common barrier that particularly junior investigators face, which is the need to develop these long-term relationships. One of the things I think CTSAs are particularly good at is creating longitudinal relationships through the community engagement infrastructures. So at Duke, we foster a number of relationships with a number of community groups that then that we already have established, and we nurture and we build that rapport and relationship, which allows then investigators to come in and leverage that existing relationship to develop their own partnerships, to ask questions, et cetera. And so we found that's been a very successful way of shortening the time period it takes to develop new relationships so that investigators can come in and begin to partner and develop relationships building on that. I think another benefit of having institutions begin to do that work is that a common complaint is that the investigators in when they have the research funding and then they're gone when the research funding is gone. And so if institutions can really begin to solidify those meaningful partnerships that go beyond a single study, you then have capacity building that's happening within the community.
And I think at Ohio State, we have a very similar approach. Almost 15 years ago, we started the Appalachian Translational Research Network that not only goes across the 30% of our state, which are part of the Appalachian region, but in fact collaborates together and partners across multiple states and more than 7 CTSAs to address those rural health and specific issues within that. And by sustaining those relationships and really listening to the community and bringing investigators together to address those in partnership with the communities, what we found is it really does help both to shorten that timeline as well as to foster additional collaborations and new areas for activity. I think the other thing that we've done is we actually advocated for and were successful at changing some aspects of our promotion and tenure process. And so one of the things that we did look is at the way that we ask external reviewers to review an individual and laying out clear criteria, both around individuals who do community engaged research and how do you look at the impact of that, which may be different than in fact discovery science or even traditional clinical research, as well as team science. And so really looking at that and kind of codifying those things that meet that, in addition to offering opportunities for extension of tenure timelines or others, I think are things that have really begun to mitigate some of the risk, not all. And it certainly will continue to be things. But I think as a land grant institution, it's front and center of what we do. It has been our 180-year responsibility to the citizens of the state of Ohio. And I know that Ohio State is very serious about thinking about how do we really respect and capture that benefit for community engagement.
Thank you all. And for those for the Washington University community, ICTS also has additional resources to help people who are interested in community engaged research, both initial partnership grants to help you establish the partnership if it isn't one that like Dr. Boulware mentioned, already part of our partnership network. But also when you have pilot awards, you get additional funding to help the community group with which you're working get additional resources, because research isn't free for the community groups either. And that's an important thing to remember. I want to take one question that came in on the chat, and then I'll wrap it up with a final question for each of you. But it builds upon the issue that you've just talked about, and that is, how do we change our institutions as leaders to really move more to recognizing that science, and increasingly impactful science, is less about an individual leadership and more about a team?
Well, I can start off the conversation, and I was thinking about the earlier comment about sustainability efforts as well. You know, this moving in with your one research project and then the funding is over, and what happens then is we have worked very hard to incorporate our health system into everything that we do in the community, because ultimately our health system has the longitudinal power to keep things going. And often that means reframing whatever we're doing in terms of research, in terms of impact on quality improvement, quality metrics that help the health system meet various goals. And so we actually have a network within rural Kansas of over 60 sites that started as an initial project in terms of acute coronary events, in terms of studying that, but then ultimately went to a quality improvement project that the health system took over and helped them meet the metrics for CMS, and they then obtained a $20 million grant that helped the health system address the rural healthcare needs. So it is, I think, sometimes we think we're in our own silos in terms of our research. We have to think about who is the partner that can go there with us to build sustainability.
Dr. Boulware, any thoughts?
Yeah, I think my thoughts sort of build off of the previous thoughts, which I think if you're thinking about impact, if you want to create impact, so I think about your translational science benefits model, which we have adopted from your CTSA here at Duke. And it's very helpful in thinking about what's the ultimate goal of your research. And when you get to the larger goals of you want to impact, a specific disease, you want to impact policy, you want to get something into a clinical setting, increasingly you realize you're going to need a lot of partners for that work. It can't be done alone. And what we need to do is really help our institutions understand how our science fits into that impact model and how that's helping to move things forward. I think we do work on, incentives like also our AP&T structure and our promotion of tenure and how we, incentivize people to work towards impact and also work on teams. Can we value team science, et cetera? I think many of our institutions are working to change some of those reward structures that we have internally. But increasingly, I think as we begin to emphasize what's the impact of the work that we're doing, perhaps we can get our institutions to begin to value what's really required in terms of working with teams to get those outcomes.
Dr. Jackson?
And I think that the important thing to think about is you don't do this at the end of the process, you do it at the beginning. And so that all those stakeholders need to be engaged from the very beginning, so that you actually craft an aligned vision. And that includes, I think, your institutional representation as well. So how do you think about how your institution, what do they want to do? How do they want to impact that? How is a health system going to improve its quality? How is research going to drive some of those activities? And what are the bidirectional methods of communication so that we all work in some ways in alignment? And I think when we do that, that's really kind of the secret sauce, right? Bringing all those different perspectives forward to allow us to do things that none of us could do by ourselves.
Well, I think we could spend another hour talking about these issues. There are already some questions that have come in that are provocative and thoughtful, but unfortunately, we have come to the end of this session, and we have a really important and engaging speaker coming up next. But I want to thank all three of our presenters and all of you for listening in. And I particularly want to thank Ebony and Becky for putting up with the technical challenges that we had at the beginning, but all three of you for participating this morning. Thank you very, very much.